Good afternoon, everyone. My name is Morgan from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us for the fourth webinar in the series for the New England Home Health Collaborative. Today's session is on improving physician-clinician communication. Before we get started, I'm going to review a few housekeeping items. This webinar will be recorded and available within a few business days on our website. I'll provide you with details on accessing that recording at the end of the webinar. The phone lines are on mute for the duration of the presentation. We will be taking questions at the end, and I will give you instructions on how to unmute your line at that time. Now I'd like to introduce today's speaker, Roby. Kathy is the Connecticut Home Health Lead for the New England Quality Innovation Network and Quality Improvement Organization. Kathy is a registered nurse with over 40 years of experience in home health care. She specializes in quality management, improving home health provider-clinician outcomes, and reducing acute care hospitalizations for Connecticut home care providers. So please welcome Roby.
Good afternoon, everyone. And we're very happy here in Connecticut because summer decided to beat a hasty retreat after toasting us for 3 or 4 days, and it's actually gone back to spring. It is beautiful here. Welcome to our session today. I know that in our original schedule we were planning to discuss the cholesterol reduction measure. However, the more I thought about it, the more I thought perhaps we should have a conversation about improving our relationships with physicians before we tackle a measure that's going to require us to actually get laboratory data back and forth between our records and theirs. So today we're going to actually be talking about clinical collaboration and how we can improve that communication pathway. As we begin today, I do want to review once again, as I will each month, that this program is being brought to you by the New England Quality Innovation Network, the Quality Improvement Organization for the 6 New England states. It's a partnership between health-centric advisors who works with the Massachusetts, Maine, and Rhode Island providers, and Qualidigm, who works with the Connecticut, New Hampshire, and Vermont agencies. Our website is on your screen, and this is the location for where you'll find today's webinar and all of the previous ones that we've done, as well as a tremendous amount of other information that applies to all the different steps along the continuum. We encourage you to click on that link, go to this website, where you'll see we've circled for you where you'll find a tab that is intended to be for all of us as providers. And you'll see that it's reminding you that for home health, we are focusing on cardiac health and care coordination. When you click on the For Providers tab, the drop-down will show you all the different sections that it has, and the second one in line is home health. Once you've clicked on that tab, the Events button will take you to each of the different programs that we've done so far. We encourage you to go back and listen to them. You can use them for staff training, and they will remain up there and available to you throughout the course of this project. I'd like to take a moment to go through the new members who have joined our Home Health Collaborative. I'm not going to read all the individual names because, as you will see, the list is very long. But we are delighted to say that we have an extensive number of agencies that have joined our collaborative, and I believe that including all the many branches that some of our larger providers bring to this project, that we have nearly 200 members that have joined the collaborative across New England, and we are delighted to have each and every one of you. As you can see, Doreen's been very busy up there in Maine. She's got quite a group, and if there are folks on the line that have not yet joined the collaborative, as we go through the slides, watch for your state and know that you can contact any one of these people and you can still join this project at any time. Massachusetts added quite a number of people in this last month since we last spoke. We have added 5 in New Hampshire, and I believe we have added 9 in Rhode Island. Oh, I take that back. We've actually added 14. Quite a large group there, and more in Vermont. As I said to you, today's topic is not the home health quality improvement measure for reducing and controlling cholesterol levels. And why not? Because to achieve improvement in this particular measure requires effective two-way physician-clinician communication of laboratory results and other additional information. And if we were to be 100% honest with ourselves and with each other, I think that we would have to agree the answer to the question, are we there yet, is probably not. Partnering with physicians is a critical element in having a successful plan of care. How well do we communicate with each other? Can we improve this collaboration by improving communication? I think that one of the many difficulties that we have has to do with how each of us are trained. It's a very different world when you're a person going through medical school. Communication and communication pathways in medical school are taught along the Joe Friday line, just the facts, ma'am. I know I'm old, but Dragnet was a part of my life, and I know that this is the methodology. Young physicians-to-be are taught to keep it short, focus on the current chronic complaint, and move on. Whereas in nursing school, we're taught to use SOAP charting. We're taught to gather all kinds of information and to include a great deal of detail. While that may be helpful, it unfortunately is a totally different approach to communication than the physician community that we're working with, and that can often cause us to lose patience with one another. There are other obstacles as well. Part of it has to do with with our perception of each other. Do we truly regard each other as peer professionals? Or is there an atmosphere of, I'm the team captain speaking here, and you are just a rookie recruit. You will do what I say, and I don't really need to hear from you. How do we present to each other when we speak to one another? Are we professional and respectful? Or does one party come across as abrupt and annoyed and in a hurry, while the other is chatty and overly friendly with lots of detail? How do we go about establishing an open, respectful communication process with one another that does, in fact, identify us as peer professionals with an equally important role in the care team that is working with the patient in question? If you were participating with a QIO organization during the 8th scope of work, which I realize was quite a number of years ago, the term SBAR may well be very familiar to you. We trained a great many nurses, a great many clinicians in the SBAR methodology back when we were actively pursuing the 8th scope and its goals. If your agency learned this method, if you've been teaching your nurses and practicing it all along, I would venture to guess that your communication pathways with your physicians are better than many others. SBAR is a technique for improving those communication pathways, for giving us a means of ensuring that we do treat one another as peer professionals, that we do provide information in a clear, concise, accurate format that encourages a professional exchange and the necessary orders and information being communicated. Let's take a look at where we were for those who either didn't learn SBAR during the 8th scope or who have since no longer decided to practice that. Previously, and for those many nurses today, clinical conversations are occurring about patient situations, and they lack a clear purpose, and even more important, they lack direction. It's as though the train did leave the station without knowing where it was going and very nervous about the process. When your clinicians contact a physician, a physician's office, a clinic, a practice, whomever it is that they are trying to communicate with, do they make that call with their basis for the communication being that they're seeking validation, they're looking for empathy and support regarding their patient concerns? When difficult situations occur in the patient's home, a weather situation, you urgently need a patient emergent plan approved, do they enter into crisis mode, conveying their own highly increasing anxiety? When that situation occurs, and in many other daily situations, clinicians are finding they have difficulty expressing their concerns, conveying the information in a very clear, concise format. So you need to ask yourself, what kind of a format are you using in your agency? How are your staff communicating information and obtaining orders? Is that process efficient and data-driven? You might find it of interest. I know with electronic records, we don't often or anywhere near as often see our clinicians in the office. If you have the opportunity, you really do want to overhear without participating the conversations that your clinicians are having, not only with the physicians, the PAs, the APRNs, but also with other peer professionals, discharge planners, transition coordinators, responsible caregivers or family members. We need to be sure that the process is efficient and very clear. We need to use a standardized format when we communicate among disciplines, no matter who that discipline is. We need to provide a process for our clinicians that will give them the structure and the guidance they need so that they can present patient situations to a physician and to all the members of the care team in a manner that is going to earn respect and to get them the results they desire. We need to go beyond the emotional components of the discussions we have about our patients so that we can accurately, efficiently address all the clinical issues we need to resolve. So our recommendation is you need to adopt the SBAR format. It's going to allow you to present yourselves, to present your patient situations and obtain orders in a professional, concise, and data-driven manner. In other words, this will give us a mechanism to put patient safety first and foremost. So here's the real definition of what SBAR means. S stands for the situation. What exactly is going on with this particular patient? You need to be able to present a concise statement of the problem with pertinent details only. What's the background? If the situation is the current predisposing issue, the background is what came before. You need to know what are the pre-existing things that affect this particular situation. Only those pieces that are pertinent. The A stands for assessment. What did you find? You need to present the clear clinical data and what you believe your analysis is and what potential options there might be to resolve the situation. Lastly, the R is a recommendation. Of the different options, what action step or recommendation do you believe is the first priority to address the situation? Literally, what is it that you want or need from this physician, APRN, PA, whomever you are speaking to? What exactly is it that you believe you need to correct the issue at hand? Consider the factors that affect how we eat and communicate with one another. As I said, nurses are taught to be narrative and descriptive. Physicians are taught to be problem solvers, and they only want the headlines. What about the other members of your care team? Therapy staff, PT, OT, and speech are educated throughout their training to be very objective, data-driven, express the situation in measurements, ambulation so many feet, range of motion so many degrees. What about the other members of the team? What about the home health aide? What about the social worker? They too have always been taught to be more narrative and descriptive. But that's going to take time, and time is a precious commodity. There's the teamwork factor. Nurses do not always see the care environment as one that is collaborative and team-based. And yet, physicians have been taught to view their care environment as collaborative within their discipline. The issue we need to address is how do we get the two respective teams where we have each learned to see the care environment as collaborative only within our own discipline. And yet, we need to collaborate with one another in order for this to be effective. That collaboration is going to need to be based on positive, effective communication. So let's take a look at a communication cycle. This is a model that will enable you and your staff to use assertiveness in a professional and respectful way so that you can get each other's attention and come together as one large team, not the team of clinicians in your agency and the team in the physician's office, but one team all working together to assist that patient in the situation. You must get the other person's attention. How will you do that? By phone, by fax, by email, by snail mail. In some fashion, depending upon the urgency of the situation, you need to get their attention. Once you've done that, you need to express your concern. Just like that, you get someone in the physician's office on the phone. My name is Kathy, and I'm calling about Mrs. Jones, and I have a concern. State the problem. Be very clear. Her hypertension is exacerbated today. Her blood pressures are up, and I'm concerned that she needs a medication change. There you go. I've stated my problem. I need to give them more data in terms of the vital signs have changed from what to what, but I've also proposed an action. We need a change in medication. Hopefully a discussion will ensue, a decision will be reached, and you can move forward from there. But it's a cycle, and we need to work together. So let's take a look at how we can apply the SBAR techniques in your agency. What are the particular kinds of patient information you have to have immediately available in front of you before you dial the physician office number? You need to know exactly who it is you're speaking about. You may or may not need the medical record number. You need to know their age, primary diagnosis, or the diagnosis to which your issue relates, the current med list, allergies, your physical assessment information, vital signs, lab results, and depending upon the situation, you definitely should have access to their advanced directive status. The next piece is you need to be sure that a physical assessment has been completed. Before you contact the physician, have I seen and assessed this patient? If I'm the one calling, I should be preferably the person who actually did do the assessment. Did I review the chart to make sure I had the right physician and all of the right information? Is there a component to my care plan of phone monitoring, phone calls that are made routinely to the patient to obtain information? Is there telehealth data, teletriage data? You should have all the applicable data immediately at hand, preferably on the screen in front of you or right there on your desk before you start to dial. Once you get that person on the phone, use the SBAR technique as we've described it so that you will know and have ready for you exactly what you need to present. In the situation, what is the situation you are reporting? Identify yourself, your agency, the patient, and their location. Otherwise, when you're calling a physician practice, especially a large and busy one, they most likely have at least 10 Mrs. Smiths, 4 of whom are in a skilled facility, 3 live in assisted living, and the other 3 live at home. Now, there's a problem. They need to know that it's Madeline H. Smith, 85, who lives at Green Garden Assisted Living. That makes a difference. What's going on with this person? Present a very concise statement of the problem. Then you want to look at giving them at least a limited but very clear and pertinent set of background information. What was the admitting diagnosis when you opened this case? If this is not the diagnosis you're calling about, if you admitted this patient because they had an exacerbation of CHF, but the reason that you're calling today is because they're also diabetic and their blood sugar is spiking, you're going to need to relate both, but identify which diagnosis you're focusing on. Have the medications available, but only bring up those medications that are relevant to the issue you're calling about. Have available the allergies, any other things that are going on in the home, so that if the physician proposes a medication, you need to be able to say, I believe this person may have had an allergic reaction. According to the information we were given, perhaps you have other information in your record. You need the most recent vital signs and assessments from that day and any other lab results that you may have, giving them the date and time if it's available and any other previous laboratory information for comparison. What are your findings? What were those vital signs? Breath sounds, weights, blood sugars, other lab work. What is your assessment? Are you comfortable? Have you trained your clinicians well enough that they are able to say, this patient's weight is up by 4 pounds, the blood pressure is up, it's gone from this to that. However, I also know that this person did not follow their diet over the last 2 days. I've re-educated them, but I do believe they may be retaining excessive amounts of fluid, and I do believe if we don't intervene, they will likely end up in the emergency room. So you need to be able to say, what are my findings? What does this mean? What's my assessment and analysis? What other options do you think there might be? And how urgent is this? If we don't intervene, are they going to be in the emergency room? Is something acute going to happen? What exactly do you want from the person you're calling? Do you need a medication change? Do you want them seen in the office? You need to actually lay that on the table with a solution. If you choose to increase the Lasix from this to that, I will go back tonight and weigh the patient and reassess, and again in the morning, and I will let you know the outcome. These are important issues. It doesn't do anyone any good for us to present the information and then just leave the phone with open air. The physician is going to be looking for something from you that indicates that you've made an assessment and that you do have a potential solution for discussion. These are the kinds of things that will allow you to be identified and respected as a clinician, as a full-fledged member of the team. How can you bring SBAR to your agency? There's a patient scenario that we're going to take a look at next. Use this patient scenario. Have a team meeting, a staff meeting. Have two members of your staff play out the roles of the clinician and the physician office you're trying to contact. Have them play it out without any preparation. Just give them the scenario and ask them to go through. Having done that in front of the group, then go through the next 10 slides as your training module. Then go back. Use the same original scenario and have them redo it. I'm sure that you have many different patient scenarios in your daily practice that you can use. You want to use groups that are 4 to 6 staff members together so that they can role play out and then critique one another, trade places, trade roles, perhaps offer a scenario from their own visits they made that morning. Once that has happened, you will then be able to validate their competency and know whether or not they're understanding what you're presenting and that they're going to be able to begin to implement it. But we have to keep reinforcing it. Just doing the training and the scenarios one time is not going to get the job done. This type of a behavior change is going to require ongoing, almost daily reminders and validation from your clinical management staff. So let's take a look at that patient scenario, the staff training tool that I've provided. Here is your case. Mr. Nelson is 71 years old, has a history of hypertension and COPD. For the last 2 days, the patient tells you today he's just exhausted. He's so weak that he could barely stand, could barely get to the door. He gets so dizzy when he stands up. And you know, it all started after he started that new medication. When the nurse reviews the medication profile against the medications in the home, she determines that this gentleman has a prescription bottle with low pressure and a prescription bottle with metoprolol. So that since that second bottle was filled at a different pharmacy, the patient did not know he was taking two of the same thing, and the pharmacist didn't pick it up because it was a different pharmacy. You have the vital signs, you know what his previous levels were, and clearly he's got postural hypotension, and he's had a very significant drop in his baseline sitting positions. What are we going to do? How are we going to go about getting a hold of the physician? This is what you're looking for your nurses to say when they first reach the physician. This is Nancy. I'm from ABC Home Care. I'm calling about Mr. James Nelson, your 71-year-old patient, who is having episodes of syncope. We've been seeing Mr. Nelson for 3 weeks for an exacerbation of his high blood pressure. Present the previous vital signs. He's complaining of lightheadedness, weakness, and syncope. Today's vital signs were, in medication profile review and reviewing the meds in the home, I identified that the patient has been taking a double dose of his antihypertensive medication for the last 4 days. Due to his having filled the new prescription at a different pharmacy and receiving a generic that he did not recognize was the same as what he was already taking. You've explained the reason as your assessment that he refilled at a different pharmacy and that his hypertension is from the medication error. I would like to hold his blood pressure medication until tomorrow. We will schedule 2 extra skilled nursing visits beginning tomorrow to recheck his blood pressure and for medication teaching. If you agree, what are the blood pressure parameters for resuming the medication, and at what dose would you like us to do that? This is a documentation tool that you can use. Nurses don't necessarily have to fill it out unless they're really struggling. with having all the information and the data right at hand. They can simply keep it available in front of them so that they will know they actually have all the pieces of information that they need to have. By using this process, by actually using the tool to guide their conversation, the likelihood that they are going to get a prompt, courteous, professional response, and that the more they do that and have these kinds of positive interactions, the more likely it is that the physician is going to pick up the phone rather than not coming to the phone when they call in. You will find, as you work with your staff, that if you were to initially time them out before training, as they present a scenario to show their baseline level of knowledge, it's likely that their presentation of the patient situation and the background and what they think is going on is going to take upwards of a full minute. It doesn't sound like a long time until you're actually timing it. With training and practice, your clinicians can present the SBAR, obtain the order, which they then simply fax over for signature. They can do that in 10 to 15 seconds. It doesn't sound like a lot, but when you're a physician with 5 exam rooms, a full waiting room, somebody in every room, and an hour behind already, 45 seconds is night and day. It's the difference between, I know who that is, I'll take the call because I can deal with it and it's done. Oh, I won't talk to that one because they'll keep me on the phone forever and it's mostly nonsense. So I strongly urge that you do this training and work toward achieving this objective. Get your contact and communication with physicians concise, data-driven, and highly professional. And you will find your communication patterns and your communication results will be significantly improved. I hope that you find this training helpful. I hope that you will let us know if this is something that you are able to use in training your staff. If there are additional tools that we can provide you to help with this training, please let us know when you receive the post-program evaluation. Before we end today, I'd like to go back and speak a little bit about the HHQI data collection. Have you registered your agency on the HHQI cardiovascular data? The registry needs you to go online, enter your agency, the contact person, and a very small amount of CASPR data into the data registry section. This will get you all set up. So before you go online to HHQI to get registered, set your agency up in the cardiovascular data registry, go to CASPR, run your most recent data period for process outcome measures. There are a couple of pieces of data at the very top of that report that you're going to need. So run that report in CASPR, have it in front of you, and then go to the HHQI website and go to the data registry so you can set yourselves up on there to enter data at a later date. Once you've done that, take a look at the measures. If you haven't selected one yet, it's not a problem. We all progress at our own rate in this project. What works best for your agency will work best for your agency. It's that simple. No one is expecting you to go on there today, get registered, get the information for all 6 measures, and charge right in. For this month, we will be thrilled if everyone goes onto the website, sets their agency up, and make sure you're registered in the data registry. If you feel comfortable, take a look at the measures and take just one, something that you think that you can begin to work on. And then think about how you would like to describe this project, your goals, and the data collection process to your staff. Remember that if you look at some of the previous webinars, We've shown you the screen, how to get registered, how to look at the different measures, and what they are, so that you can start small with smoking cessation or aspirin usage and begin to implement one of these measures. But for now, for May, let's just get everybody registered and download the best practice information packages so you'll have them on hand. We did discuss that if you want to make your data collection easier, you can include the HHQI literature in admission packets. You can insert that single-page data collection tool into admission charts or existing charts so that your staff can begin putting the name and whether or not they are Medicare, Medicaid eligible on the form, and then simply answer the measure question when they're ready to discharge. Identify a central location and a data collection, data entry person who will be the one who goes online to the registry to do the data entry when you're ready. Remember Million Hearts? Don't forget, even if the only thing you can do right now is to go onto the website and indicate that your agency supports the mission of reducing the risk of cardiovascular incidents and improving medication compliance. That's all you need to do for now. If that's enough, if that's all you can manage, it is absolutely fine. You might want to consider, now that the weather is so beautiful and finally all the snow is gone, perhaps you might like to have a noontime walker's time. Post a poster up in your kitchen at 12 noon. A group of us are going to go outside. We might walk 3 loops around the parking lot. Maybe only 1, maybe 5. You do what you're comfortable doing, but join us. These are simple things that you can do that will have a tremendous impact on your own staff. So that brings me pretty near to the end of our presentation today. I do want to encourage you to begin to share with one another. Our goal is that working together, we can improve the outcomes of our patients' episodes of care. We need to work together. I know I'm old, but when I started in home health, we were less concerned about whether or not someone took a patient in the community I was serving, and more concerned about helping one another to meet that goal of improving all of our patients' outcomes. So right now, I'd like to invite everyone on the phone to share whatever is working well for you. Offer some suggestions to one another. Offer some suggestions to us on what ideas you might have for webinars in the future. And if someone out there is struggling with something, having difficulty getting staff to implement some changes, having difficulty getting them to consider doing one of the measures, we're going to open the phone lines now and throw the floor open for you to reach out to one another and to us here. Morgan?
Alrighty, so if you guys have any questions, if you would press *6 on your phone to unmute your line, you can go ahead and ask your question.
I haven't heard anyone. Hello? Does someone have a question? No? Well, we'll leave the lines open while we finish up for today. Please remember that every third Thursday, which is next week on Thursday, there will be an educational webinar from HHQI related to the project itself. Don't forget to register. If you haven't received an email reminder to register, you can go to the HHQI website and register there. It's Thursday, May 21st at 2 p.m. On the HHQI website, you will also find all their previous webinars archived, ready and available to you, as always, at no cost to you. Lastly, I would encourage you to go back to their website, take a look at their newest section called HHQI University. It is wonderful. They have tremendous webinars, programs, all taped, all ready for you, and many of these will offer CEUs to your staff. It's a tremendous opportunity. One last thing before we close today, I do want to let everyone know that representatives of the QIN-QIO will be at the New England Home Care Regional Conference next week, which opens on Tuesday the 19th and ends on Thursday the 21st in the afternoon. We will have a small exhibit in the exhibit hall. Georgette and I will be staffing it along with anyone else from the QIN-QIO, from Health Centric or Qualidine who is able to get there. If you have any questions, anything you'd like to discuss with us that you don't feel comfortable sharing on an open line, we would very much like to hear from you. So look for us. We'll be right near the food. You can find us next to the coffee pot. It's a perfect location. I look forward to seeing you there, and I'll be talking to you next month.
So just to make sure, if anybody has a question,
Hello, yes.
I just want to say thank you, Kathy, for this presentation. It was very good.
You are welcome.
Thank you.
all right. Well, if we have any questions, go ahead and press *6 on your phone. If not, I wanted to let you all know that you will receive a follow-up email tomorrow with a link to a brief evaluation about today's webinar. We would really appreciate it if you complete that, as your feedback is important and it does help us, update our, PowerPoints and presentations to make sure they're useful for you. In there, you'll also receive a link to where you can find the recording, presentation, and also a transcript of today's webinar. It'll take about a week for those documents to get on there, but if you keep that link, you'll be able to access them. We'll also include a link in the invitation for our next webinar, which is on June 10th on improving patient engagement. So thank you all again for joining, and be on the lookout for that evaluation.
Thank you, everyone. My contact information is up on the screen. If you have any other questions, topics you'd like us to do in the future, please don't hesitate to reach out, not just to me, but to the contact folks for your state. Have a great day. Bye now.